Good afternoon, everyone. I think that we can start now. We're delighted to welcome you to the third Core Knowledge Hub meeting, which will focus on effective engagement strategies for migrant communities in Europe in HIV testing initiatives. Before we proceed with introducing the speakers, let us agree on the housekeeping rules. So this event is being recorded. Please put yourself on mute unless you are speaking. You can ask the questions throughout the meeting in the chat or during the Q&A session by clicking on the raising hand. Now let me remind you what CORE project is. So CORE is a European Commission co-funded project which aims to reduce inequalities in the HIV, TB, and viral hepatitis responses by promoting, strengthening, and integrating the community responses that have proven key in reaching communities traditionally underserved by mainstream prevention and healthcare services. The Knowledge Hub is a series of online meetings designed to share the community-led best practices in community health services and to discuss the solutions to the issues encountered. Let me now pass the floor to Denis and Onyango from Africa Advocacy Foundation to introduce today's speakers and give a short overview of the webinar objectives and its significance.
And hello, everyone. Good afternoon, and thank you for joining us for this webinar today. As Nataliia said, this webinar is aimed at exploring effective engagement strategies for migrant communities in Europe, especially with regards to testing. We have put together this webinar to be able to highlight, obviously, the various barriers that we experience working with migrants or being migrants in Europe with regards to not only HIV testing, but of course, prevention and treatment as well. We have with us speakers who are going to share with us, some of the experiences of working with migrants directly and how effectively they have worked to engage migrants in various, localities or in various member states. We'll also be looking at how culturally competent services are supposed to be to enable engagement. We are going to examine the role of peer educators and the role that they play in engaging migrants in testing initiatives. And of course, we're also going to look at some of the recommendations to healthcare professionals, to policymakers and community organizations who are working with migrants. And so I'm going to start off by introducing our speakers. So I will also play a role in the Q&A session where I'll be chairing the session. So as Mohammed has indicated in the chat, if you have any questions for our speakers, please do drop them in the chat or just raise up your hand when we're in the Q&A session. I will start. So we have three wonderful speakers today. I'll start with Carter of Hirwa, who is known to most of you, at least who are in this sector, but I'll introduce him anyway. He's a Rwandan-born trans activist, speaker and publisher and community researcher based in Belgium. As a proud gay trans migrant man, he brings lived experiences to the heart of his work in HIV prevention and health equity. His 2022 publication, Healthcare Access of Trans People in Rwanda, reflects a deep commitment to justice-driven, community-led research. Through roles in EATG's core and scope projects and years of grassroots organizing, Carter develops engagement strategies rooted in trust, care, and cultural relevance. Known for his powerful storytelling, he creates spaces where trans and migrant communities lead inclusive, compassionate, and transformative HIV responses. Carter, welcome. We are happy to have you with us this afternoon. I know you're traveling, so we will bear with you, but really, really thank you for joining. The second speaker is my colleague, Flaherty-Gupta, who is known to you mostly as the programs manager for My Health Europe project, in which we've been working with a range of partners across Europe since 2020. Anne is a social worker with over 10 years experience and providing direct services and developing and managing programs both in clinical and community setting. She holds a master's in social work with a concentration in mental health and a certificate in violence studies from University of Illinois in Chicago, and an MSc in psychological sciences from Brunel University here in the UK. She has provided individual and group therapy to migrant and criminal legal system involved teens and adults in the United States. And she, as I mentioned before, she's been working over the past many years in trying to get migrants in Europe to access testing, prevention, and treatment. Anne, you're welcome, and we are glad to have you here with us. Last but not least, my colleague and friend, Anne Piercy, who is based in Ireland, who holds the position of a community HIV testing coordinator, mobile testing at HIV Ireland. She is very conversant with migration health, having worked with migrants for many years. She's dedicated to reducing the prevalence of HIV in Ireland by implementing effective prevention strategies. Her efforts aim to contribute to a significant decrease in HIV incidence and prevalence, leading to the realization of an AIDS-free generation, and is an active member of EATG and serves on the CAB Ireland. Anne, you're most welcome. So we have two Annes today. I will be referring to Anne FG and Anne P. So when I say Anne FG, you know, it's Anne Flaherty-Gupta, and if I say Anne P, it is Anne Piercy. So you're all welcome, and thank you very much. I will start by inviting Anne Flaherty-Gupta to start her presentation. So Anne, feel free to begin.
Yeah, thanks, Denis, and thanks, Nataliia. I'll just share my screen here really quickly. Okay. I am trusting that you can all see that. So again, my name is Anne Flaherty-Gupta. I'm with Africa Advocacy Foundation, and I'll be talking about HIV and migration, the policy and data landscape here in Europe. Yeah, so we'll go ahead and get started. So I'll just give a quick overview of HIV epidemiology here in Europe based on 2023 data, and that's the year for which we have the most recent data available from the ECDC. So just for reference, in 2023, about 14% of the EU's population was composed of migrants, but there's clearly a disproportionate burden. So migrants defined by the ECDC are anybody born outside of the reporting country. And when they had all of that data, when they had complete data about the origin information, migrants were 55.8% of HIV diagnoses in 2023. When that data was missing, migrants still accounted for 47.9% of HIV diagnoses in the region. There are also considerable rates of late diagnoses among migrants. So overall in the EU, 52.4% of people were diagnosed late, but that's compared to 58.6% of migrants from sub-Saharan Africa and 61.1% of migrants from South and Southeast Asia. There's still a disproportionate burden when it gets to transmission mode as well. So of all the people reporting sex between men as the main form or as the form of transmission, 44% of those people were migrants. Of those reporting injection drug use as the mode of transmission, about half were migrants. And almost 2/3 of those reporting heterosexual transmission were migrants. Finally, about close to 80% of mother-to-child transmission occurred amongst migrants in 2023. So despite these statistics, the existing data on migrants tends to be pretty inadequate, incomplete, and inconsistent. So the ECDC reports that countries use different definitions of migrants. They use different sample sizes, different sampling timeframes, different analysis techniques. There's also issues with data quality and missing data. So for example, data on migrants with irregular statuses, like undocumented migrants, is often completely unavailable in the region. Crucially, the data often doesn't differentiate between new HIV diagnoses and those who had previously been diagnosed abroad. Finally, the chart there on the right shows that only 5 countries in 2023 out of 30 in the EU could report on all 4 stages of the HIV continuum of care for migrants. Those countries were Austria, Belgium, Czechia, Greece, and Luxembourg. And then there were 18 countries in the region that couldn't provide any continuum of care data whatsoever on migrants. So there's quite an impact on this poor quality of data. It limits our ability to really illustrate HIV epidemiology amongst migrants. It obscures the intersecting vulnerabilities and precarities in migrant subgroups, both within and between countries. And it limits our ability to effectively allocate resources and develop programming, and not to mention to evidence data-driven policy. There's also really limited data that is available on migrants' ability to access PrEP. So 16 countries reported trouble in reaching undocumented migrants with PrEP in 2023, and 13 countries reported trouble reaching documented migrants as well for PrEP. Only 4 countries could actually report on the number of migrants who accessed PrEP in 2023. So in Portugal, about 22% of all people who accessed PrEP were migrants. In Cyprus, it was about 24% of people who accessed PrEP were migrants. It was 13% of people in Czechia, and Malta with 1 migrant. It was less than 1% of those people in Malta who accessed PrEP who were migrants. So turning towards the policy gaps in Europe, I'm not going to read the whole quote. It is a bit long, but I just think it really highlights the barriers that especially undocumented migrants face, and those barriers really underpin the HIV-related policy decisions for all migrants in the region and how it impacts everybody much more broadly. So for an overview of the policy barriers faced by migrants in Europe, in many countries, undocumented migrants are eligible to access only emergency or essential healthcare. But what is considered emergency and essential care really depends on the country. Those definitions are quite different between the different countries. And this leads to late diagnoses and poorer health outcomes for migrants. It also causes a paradox for healthcare providers. So on the one hand, if they provide care to migrants, especially undocumented migrants, they act against the legal requirements and the health insurance reimbursement protocols in their area. But if they refuse care, they're violating human rights and they're excluding some of the most vulnerable populations. Some countries also have reporting requirements, so they're forced to share data between healthcare and immigration authorities. And this understandably erodes migrants' trust in the healthcare system. It increases fear of detention or deportation, and it limits the care that they can access. There are also health system literacy issues, and these function as barriers as well, and they kind of go 2 ways for these barriers. So on the one hand, you have frontline healthcare professionals who are often unaware of the rights and entitlements that different people have to care depending on their immigration status. And this can lead to the denial of care or increased administrative burdens. There's also just differences in interpretation services that are available in the region as well. On the other hand, you have migrants themselves who are oftentimes unaware of how to navigate healthcare systems in their host country, and they might not be aware of their rights. So this can lead to the underutilization of services and delays in accessing care. Additionally, rights are often not available or not made available in the languages that migrants can understand, and this further pushes migrants away from care systems. There are issues with the healthcare providers' biases or their attitudes as well. So providers can have racist or paternalistic attitudes, and they might not offer information on the latest biomedical advancements to migrants, like about PrEP, because they assume that they can't legally access the treatment, or they're not ready to talk about sexual health or sex, or simply that they couldn't afford the treatment. And this means that migrants are blocked from receiving non-stigmatizing and best practice care, and also the latest interventions. And then finally, there's a lack of regular and safe immigration routes to Europe. So the EU's immigration policy is largely based on deterrence of irregular migration, and to do so, they create hostile policies. So these policies force people to travel in increasingly dangerous conditions and routes, and they're often exposed to trauma and abuse. They have strict conditions on staying in the EU too once they arrive, and those conditions are typically underpinned by policing and immigration detention. And then finally, they're restricted from accessing health and social protection mechanisms as well once they arrive. So finally, we'll look at some more barriers that are more specific to HIV. So Some of the national HIV plans don't mention migrants at all in the EU, although it is worth noting that 24 out of 28 countries have national HIV plans that do mention migrants, but Denmark, Estonia, Iceland, and Slovakia don't mention migrants at all. And Iceland actually doesn't even have a national prevention plan. And then only half of the countries reported that condoms and lubricants are available for free for migrants. So in half the region, migrants are paying for those products as well. And finally, only 11 countries reported that migrants participated in developing the national policies and guidelines that they have in place. And all of this leads to poor health outcomes and possibly increased rates of HIV transmission, limited access to information and care, and the increased fear of discrimination and deportation. It also just undermines countries' abilities to reach their own national goals for ending new HIV cases. It's worth looking at PrEP again too. So PrEP actually isn't even available in all countries in the EU, regardless of immigration status. But beyond that, 7 countries say that PrEP is not available for undocumented migrants. So Croatia, Denmark, Iceland, Luxembourg, Romania, Slovakia, and Slovenia don't allow undocumented migrants to officially access PrEP. And then there's 5 countries where undocumented migrants can access it, but only if they can afford it, only if they can pay. So Finland, Germany, Malta, Netherlands, and Sweden. And again, this is just limiting access to prevention and treatment and leads certainly to poorer health outcomes and possibly higher rates of HIV. And then finally, the last bit we'll talk about is criminalization. So even though that's not specific to migrants, there's still criminalization of HIV transmission in Europe. And so the map here indicates that 4 countries in 2023 had laws that criminalized HIV transmission, non-disclosure, or exposure to HIV. And 18 countries reported that although there are no specific criminalization laws, prosecutions still occur based on general criminal laws. And these laws lead to increased HIV prevalence amongst key populations because people are aggressively policed and they're stigmatized and they're pushed further away from healthcare at that point. And the last bit is that key populations are criminalized, and we know that this intersects pretty heavily with some precarious immigration statuses. So migrant sex workers, migrants who use drugs, migrant men who have sex with men, trans migrants. In 2023, 8 countries had laws that criminalized aspects of sex work. Drug possession is a criminal offense in 18 countries, and 2 countries have laws that limit the LGBTQ communities. So yeah, thank you so much. I will pass it back, I think, to Denis at this point.
Thank you, Anne. Right on time. Thank you for your very insightful presentation, detailing very clearly the various challenges, both system-wide national policy and, of course, practical challenges around across the cascade of care for migrants. So thank you for that. We will follow. Hold your questions until the end. I know that you might have some questions. So I will take this opportunity to invite Anne Piercy to also share with us her presentation.
Hi, everyone, and thanks, CORE, for actually inviting us to do the talk on this subject. I'm going to present the mobile testing unit that HIV Ireland, I as a coordinator, are running at the moment. It's called Eco Check and Chat. Check and Chat equals peace of mind. And the mobile unit that we'll be discussing today is what you're seeing right now. The mobile testing unit actually brings rapid testing to the community. This is another mode of mobile testing unit, and it's called Lucy. So just keep the 2 in mind. So we've got the van, and we've also got this mobile testing unit, which is a vanity case, where if we don't want to bring, or if we have been invited to do testing somewhere and they don't want us to rock up with a van, we actually bring the vanity case. We just call a taxi, put the vanity case in the taxi, and off we go. So as I introduce myself, my name is Anne Piercy. I'm the project coordinator of HIV Ireland, and the project's name is called Eco Check and Chat. I'll talk about the challenges first of STI testing, And then I will talk about the innovation that we have created here in Ireland, which is community-based. We actually, we have migrant community who are actually running or they're managing the testing unit. So the challenges that I'm going to talk about the migrants communities often facing disproportional burden of HIV and STIs due to several factors. One of the factors is the navigating of complex healthcare systems when they get to the country, the language barriers, restrictive healthcare policies, which can hinder access to testing and care. Fortunately, here in Ireland, anybody who arrives in Ireland, if they arrive today or tomorrow, they can actually present themselves to STI clinic and they will be registered and they can continue their treatment. There's no things like insurance or you need to have a GB card or you need to register with a doctor. We don't have that here. The other thing is stigma, discrimination, and cultural norms surrounding sexual health can create an environment of fear and silence. Also, precarious employment, low income, and lack of health insurance. As I said, insurance here, not really. People get insurance because, they want fast service, but health services to do with HIV, they are for free. Also, previous negative experiences with healthcare providers. There's a lot of negativity when it comes to accessing healthcare services. Sometimes it's the culture. Sometimes, as you are aware, as migrant community or as migrant people, we are sometimes very loud and people perceive that as if we're shouting or screaming for services. Meanwhile, we're not. We're just trying to access services, and it's our language, it's our tone, it's the way we speak. So the mobile testing unit was launched on the 21st of November 2023, so we could say that it's a year old. It's funded by Gilead Science and GSK Viv, and also certified proud. We are in partnership with ASSET, which is the AIDS Care Education Training. EcoCheck and Chat is the name of the mobile testing unit, but the meaning of it is that you check, you chat, and by the time you leave the space, you have a peace of mind. So this innovation is minded by migrant community, as you can see in the picture. Our target population are refugees, asylum seekers, already integrated migrants, women, sex workers, and people who use substance. I've highlighted the GBMSM and trans people because here in HIV Ireland, we have Empower, which is for the GBMSM. They also have their own testing strategies, and we also have the trans testing services. So the solution, the community power testing models, we actually, what we have done is we've shifted the paradigm. We're not using the old paradigm where you go to the hospital, you line up and you wait for someone to come and say next, and then you go in. What we've done is we have actually trained volunteers from the community to actually run the service. So what I do is, my job is to just make sure that the volunteers are trained and educated about testing and about STIs. And also the model is tailored to, it's tailored to migrants, but also, as I've mentioned, to people that are using substance, sex workers, and all the others. So when we're doing training, we just don't train people about how to interact with migrants, but we train them to interact with anybody or everybody. And by the way, if somebody who identifies themselves as GBMSM or as trans person, they come to the van, we don't send them away. We actually welcome them to access the services. So we we do testing. Testing is offered in familiar, accessible community spaces such as community centers, places of worship. I've actually highlighted the places of worship because at the moment we have collaborated with a faith-based community where the bishop, I'm just going to say bishop because that's the title that the highest most person in that congregation is called. But we have partnered with the congregation or with this worship place where what we do is we go to the place and they give us a space. It's a very tiny little room, but it's enough for people that come to worship there. And it acts as a counseling hub. People come there to just have hot beverages, teas, coffees, and whatever they can. So that's where we go to introduce testing, to talk about STIs, and to talk about the services that we are giving. One of the things that we've done as of last week, which is a pilot project, is we are now a hub of SH24, which is the self-testing test kits. So what we have done is we take the test kits to them and we give them, and whoever comes in, the bishop and people that are volunteering with the services, they actually introduce whoever is coming to the space about testing, and whoever wants to get the test kits, they can. We did give them about 40 test kits. As of yesterday, they called me to say they only have 5. So I'm finding that that's one of the ways I think that we will be engaging with migrant community, because this place of worship is where a lot of migrants, they go to worship. Also, HIV testing is often integrated with other health and social services such as drug and alcohol rehabs, homeless shelters, mental health support housing, assistance, and legal aid to provide holistic care. We are in partnership with the Drug and Alcohol Task Force here in Dublin, and we come up with activities like 3 weeks ago, we had an activity where we went and did testing outside Dublin, but it's within Leinster area. And the uptake was very good, because what we've learned is bring some pizzas, some drinks, not alcohol, but just, beverages, soft drinks, and pizzas, cakes. People come in, talk, and most of them, they won't walk out without testing because they're already in the space. So the evidence, proven impact of testing, uptake, and engagement. The key outcomes so far, we've seen that we've increased the testing uptakes. So far, as of 2024 end, we did about 1,027 tests. 1 was positive reactive for HIV, and 16 were positive reactive for hepatitis C. Now, with the hepatitis C, what we found out as well is that when people come to do the testing, some of them would not know that if you're doing the rapid testing, which is testing for antibodies, it will come up positive. So they'll just come and then all of a sudden, oh my God, I am positive. But when you ask them, have you tested for Hep C before? And if they say yes, then we will actually let them know what is happening. We'll have to talk to we will have to explain what it means to have a positive reactive in our rapid test kits, in our rapid tests. And also we normally would refer them to an STI clinic for further assessment in case they did not follow up with taking medication. Another key outcome was early diagnosis. We do go to places like universities, third-level institutions, where in as much as people think that we are wasting our test kits, or maybe we're wasting our times because we're going to a third level institution. And when you look at the age brackets of people that you find in the universities are from maybe 20 to between 20 to 30, that age bracket. And they think that people at that age bracket, maybe they would not, they would be aware of testing, they would be aware of HIV, they would be aware of preventing, but surprisingly, most of them, they don't know anything. So when we go to these places, we're not targeting the students alone. We're also targeting people that they live with, because when they see us, they know that we're there. They will take the information home to say there was a van that was doing rapid testing, and maybe next week or following week, it's going to be in this place. And maybe if you need to go and do testing. And also some of them, they're friends. They're not in the same school. They're maybe somewhere else. They're in a different universities, or maybe they're working. So they will also pass on the message to their friends to say, guys, you need to go and test. Another key outcome would be the improved linkage to care. So this picture that I'm showing here is the one that we took 3 weeks ago. And this helped us because in this group, it's not only HIV Ireland. So we have the peer support workers in the region, and those that are doing drug and alcohol in the drug and alcohol task force. We also have people that were from the clinics to do with Hep C. And we had all the equipment on site. So what we were doing is we, as HIV clinic, because of the rapid test that we had, we did the screening. And if somebody was reactive, we would then pass them on to the clinicians to do with Hep C, who would do the whole assessment right on site and maybe given prescriptions or referred to the main hospital wherever they can. And another key outcome was the reduction of stigma. With open conversations that we always have when we go to these places, we find that because of openness, because of the van being present, everyone wants to come and hear what we are doing, or wants to come and ask us questions, because they're actually hiding in a group of people. Sometimes when we park the van somewhere where there's no people, and when they're passing and we stop them, most of them will just say, oh, no, I'm in a hurry, or no, it's not for me, or not today, or no, I wouldn't have HIV. Also, we have changed the way we present. So when we are inviting people to our van, if they're passing and we invite them to our van, what we do is the rapid test that we have is a multiplex, which is HIV and syphilis, and then we have Hep C on its own. So at first, we used to say, hi, we're doing testing and we're doing HIV, syphilis, and hepatitis C. We would notice that people would just pass by or go, no, that's not for me. I wouldn't be, not HIV, and they walk past. But then we changed. The way we do it nowadays is, hi, we are doing testing here. We're doing syphilis, hepatitis C, and HIV. The moment you start with something like syphilis, you will see that a person will stop because you have instilled syphilis at first before HIV. HIV is still, there's still a lot of stigma surrounding HIV, especially here in Ireland.
Sorry, Anne, we're running out of time. I don't know if you can breeze through the rest. We've almost 6 minutes over your time. Sorry.
No problem. And the other key outcome was the enhanced trust. So because of the space that we have, we call the van a one-stop shop, where we have different types of, we have different information. So if we see a woman with a baby on their back, we're not going to ask them, we will ask them about testing, yes, but we will also ask, has the baby been vaccinated? And if they say no, we'll say, okay, here's a flyer. This is where you can go to ask for services to do with vaccination. So we are not only focusing on the testing itself, but as a migrant, as a van which is run by migrants, we incorporate a lot of different things in it. I'm not going to dwell on that, but I think Anne FG mentioned about Anne mentioned about, the barriers to communication. If you look at this poster, I did take this poster deliberately because this is a poster that was produced by Technical College Athlone. And if you read at the bottom, with the prick of a finger, you can get tested. I've always gone back to that sentence and tried and reconstructed it. But it's actually a message. Whatever way anybody understands, it's a message that will go to a person who sees it, and they will know that, well, it's just a prick on the finger and you will get tested. So the conclusion is, by empowering migrant communities to lead the way, we can increase testing rates and reduce undiagnosed infections. We can improve health outcomes for individuals and community as a whole, and we can also build a more inclusive and responsive healthcare system. A call for action. If we have funders in this core, please invest in community-based organizations and peer-led initiatives. As for policymakers, please create an enabling environment that removes barrier to care. For healthcare providers, partner with community organizations and embrace culturally competent practices. And for the rest of us, get involved, get tested, and be a champion for health in your community. These are some of the nice, beautiful, smiley faces of our volunteers. And thank you very much, Zikomo.
Thanks, Anne, for your insightful presentation and for sharing your experiences. I think we are running a bit out of time, so I'll quickly call on Carter to join, and hopefully we'll have some time for Q&As. I know that there were a lot of questions that came through the chat, so please hold on to them. We'll make sure that we ask them to the presenters. Carter, you're most welcome. If you could share your presentation, please.
Can you hear me?
Yes, we can hear you very well.
Great, thank you. I do not have a presentation to share. I just have a few things that I want to talk about. There's so much noise. No?
We
You can.
We can't hear you now, so just carry on. If it's not possible, we'll let you know. But yeah, I think there's a bit of noise. I don't know.
Yeah, I was in a quiet place, but now I would try to raise my voice. Okay, great. So I want to talk a little bit about the political climate in Belgium and how it's affecting Black trans asylum seekers and refugees. In Belgium, I think everybody has seen that it has been the government that is the most conservative now. They are extending times for social support, increase deportation, and digitize surveillance. So in Belgium, legally, all asylum seekers in Belgium are entitled to health care, including HIV treatment under the Federal Agency for the Reception of Asylum Seekers. But in practice, it gets more complicated. To have access to HIV care often requires proof of asylum status or registration, medical records that most of the times you cannot find, and you need to understand complex bureaucracy in French or in Dutch. So, and many trans individuals that arrive do not have documents that reflect their gender identity, which leads to misgendering, refusal of services, or even delayed treatment. There is also fear of deportation. Many Black trans refugees fear that disclosing their HIV status or gender identity might not be taken seriously as a basis for asylum, and it results in stigmatization and denial of their claim, which prevents people from seeking early testing and care. There is a lot of transphobia, racism, and xenophobia, especially in some healthcare providers and reception in center staff in hospitals. And then there is lack of culturally competent and gender-affirming care, especially in rural or Flemish regions, and with fewer specialized clinics. Another problem is underfunded LGBTIQ services. There are organizations like Marahaba, Jean Pluriel, the Rainbow House, but most of the times. They are very underfunded. They may be present in or not near asylum receptions, and they might not be accessible to non-French or Dutch speakers, which takes a toll on the mental health and leads to isolation and treatments adherence, which there is poor antiretroviral therapy adherence. There is a reluctancy to access mental health support and increase the risk of HIV-related complications. So imagine arriving in a country unfamiliar with the language, carrying the weight of displacement, trauma, and hope. Now imagine doing so as a Black trans person, navigating only borders, bureaucracy, also racism, phobia, and invisibility. Have you ever had to explain your identity just to access healthcare? Now imagine doing it in a language you don't speak with someone who sees you as a threat. When you place a camera in every corner but no translator in a clinic, what message are we sending? And then I have a few strategies, some things that could be done maybe better in a way as any healthcare who is present today. Strategy one, they should be centering lived experiences. Please hire and train peer navigators, Black trans refugees. We have worked this path ourselves. Imagine walking into a clinic, being greeted by someone who looks like you, speaks your language, and understands your fear, not from theory, but from life. I'm very comfortable sharing my details with better people who look like me more than doctors. Then we need to work on language. Words can heal or harm. We need to teach clinical jargon for affirming culturally rooted phrases. Don't say screen for HIV. Say protect your body, protect your future. Language should be open. It should be opening doors and not closing them. Safe spaces are sacred. A testing site should feel like a sanctuary, visually inclusive, pronoun respecting, gender neutral, and judgment free. A warm affirming space with diverse posters, soft lighting, and multi-language signs would feel more warm. Safety is not a sign on the door. It's how people feel when they walk through it. Lastly, we are not hard to reach, but we are really invited. We are not hiding. We have been shut down. And I think it's time we build new doors and hand over the keys. So instead of asking, why don't you come to us? You should be asking us, why haven't you come to us? Think of one system you're a part of: healthcare, legal, housing. What would it mean handing over the keys? Lastly, support should be integrated. Testing is only one step. Please link it to legal aid, housing, mental health, gender affirming care, access to hormonal affirmative therapy, which is also called hormonal transition therapy, and access to gender affirming surgeries, as well as the sexual health, reproductive health. Because we are whole beings, we cannot just be put in one piece. Then I have a call to action: funding peer-led programs and hire us. Pressure policymakers for humane asylum procedures. Make inclusivity standards, not special. So I will refer my question to how do you serve us, but how do you follow our lead? Because we already know what liberation looks like. Me personally, I have already imagined it. Leadership means control over narrative, funding, and spaces. and safety. Thank you so much. I will share my presentation when I get where I'm headed. And if there are any questions, I'm happy to receive them via email. I have a few reads. If anybody is interested, I can send links to, because everything has been documented, everything I just talked about. Thank you.
Thank you, Kata, for that powerful presentation, and of course for the very, very passionate and very relatable way you've done your presentation. I do think that, a lot of the stuff you've highlighted around cultural competency and gender affirming services are really, really important, as much as, what we're seeing right now against migrants in terms of the political climate and the racism and the lack of integration that we see in many services, integrated services. So we have only 10 minutes to be able to, probably about 5-6 minutes to take some questions. And Piercy has done a great job answering some of the questions on the chat. But I don't know, Mohammed, if you have some, if there are some questions that we've left out, potentially you could pose them to our panelists. But meanwhile, I'll open the floor for just 1, 2, or 3 questions that I'll request our panelists to answer in very brief words, so that we can have everyone at least getting feedback on their questions. But yeah, I do open the floor right now if there are any questions. And if whilst we are doing that, Muhammad, if there's any questions that have not been answered on the chat, probably you could help and highlight them. Are there any hands? Yes, I can see Harriet has got her hand up. I don't know if I missed any other person, but Harriet, you're welcome. Great to see you here. Please do ask.
Yeah, it's absolutely great to see you and to follow this very, very splendid and brilliant session. And I was thinking of how much even non-migrants could benefit from all the lessons learned that I followed here today, referring to the last presentations about how much language matters. This language matters to all of us, not only to migrants. So I find it very, very important to stress out the resources and not always to focus on the lacks that we are facing, but the resources that coming with migration. And that was not a question, but a remark. And thank you all for being here and presenting.
Thank you, Harriet. Thank you. Really appreciate your comments. Do we have any other? Oh, and Piercy has a comment.
Yeah, I just wanted to also comment on that, Harriet. But what we have done so far, or what we do every year, the University of Limerick, they ask us if we can take students for work experience. So what I've so far done is I've tried to ask them to give me students from diverse backgrounds, like from Nigeria and from Asia, and also from the Middle East, because those are the people that we want to reach, but we can't reach. And sometimes it's because of language barriers. And for us to find translators or interpreters to kind of like translate all these for us, we can't do it. So what we do is, in the 8 weeks that they are with us doing their work experience, I give them an assignment of doing health promotion. So they have to come up with materials in different languages or in languages from where they're coming from. This year I had 2 students from India and 1 from Nigeria. You could see the disparities between the 2 cultures, where the 2 women with the 2 girls from India, their way of promoting sexual health was totally different from someone who's coming from Nigeria. But what I'm trying to do here, which I'm still learning myself, because this is all new for me as well. But what I'm trying to do is I'm trying to incorporate different languages and different, way of imparting information to different cultures. So if it's a person from Nigeria, they have to give me 2 or 3 languages of an Instagram post, where I will post them on our Instagram page, the Equal Check and Chat page. And by so doing, we are actually trying to reach people from that side, East of Africa. But we do engage students from the university, from diverse backgrounds, so that they help us with information. And the students that we get are the ones who are doing public health, masters in public health. Those are the ones that I always welcome in our project. Thanks.
Thanks, Anne. Thanks for that. It's very, very useful. And I do agree with that, Nataliia, that we need to be able to expand the audience of this kind of chats, conversations, because the issues are really similar. I do have a quick question for Anne Flaherty-Gupta. I think one of the issues you raised was the issue of data and the lack of it. So I just wanted to ask that, given the lack of disaggregated data on migrant populations in Europe, how do you approach evidence generation in your work whilst protecting community confidentiality and agency?
So I work with My Help Europe. We are a partnership across 11 countries in Europe, and we come together as representatives of our communities, mostly migrant-led, but certainly peer-led organizations. And we decide on the indicators that are important for our communities, the data that we want to collect. So we don't collect any identifying information that could identify any specific individual, but we do decide on the variables that are most important to our community so that we can tell our stories and our impact and evidence our needs in our own communities. And then that fills a number of plugs because the existing data is, there's a lot of gaps in it. So yeah, we're able to fill those plugs that way.
Thank you so much. I think there's a question for Hirwa asked. But anyway, that's okay. So I wanted just to ask Hirwa as well, quickly, because I've not seen any question, any hands up, or I don't know if there's any questions on the chat, Mohammed, maybe after this. But I wanted to ask Hirwa, I know you've talked passionately about the challenges that trans people communities experience, which has transphobia, racism, and all the complications around lack of recognition. If you could make one concrete recommendation to the EU or national policymakers on how to increase HIV testing amongst trans people, and not only testing, but other services, what would it be? One concrete recommendation. I know you've highlighted funding, but do you still stick with that, or is there something else?
I stick to the point where trans people cannot only be guests. We need to be co-owners in those projects. You cannot serve us if you do not know us. I will stick to that because it's the only thing that works.
Thank you. Very powerful. Thank you. Thank you so much. I really appreciate that. One final question from to Anne Piercy. And then I will again leave Mohammed again. I'm going to call again. If there's any question, please let me know. I don't want to ignore anyone's question. But Anne, very briefly, because we need to be closing in about 3 minutes. We know that peer educators are often deployed in outreach, and you've done this effectively from the example you've given us. But training and long-term support varies, and wanted to ask what you found to be essential in sustaining effective peer-led HIV testing service as the one that you're doing.
I think, for me, I think what works would be the promotion side of it, especially promoting the services to the community where they are then the peers of the testing, the mobile testing. They're the ones who take the information to the communities, and then the communities will embrace, because this is their community and they're talking to their community. I might not be part of that community because I'm outside, but what we have learned, or what I've learned, is the community, the peer-led, the volunteers that I have, they are coming from maybe asylum seeker hostels, and they've got their own WhatsApp groups. And what I do is I will impart information to them, and then they will take it to their WhatsApp group, and then information goes out. There's testing being done at this place, or you can get free tests, and you can, and the moment you just mention free, It's free testing. They don't have to go to the hospital to line up. They can just, pop up to us or to go to the place of worship, and then they'll get their tests, they'll get the services. That's what I can say. But if there's anybody who would like to, learn more, please do reach out and we can talk.
Thank you very much. So quickly, 1 minute each. Muhammad has a question, and then Hirwa, and then Nataliia will come in and close. So Muhammad, very quickly, and please, very quick, very 30 seconds responses.
No, I think I was just highlighting there was a question by Daniel Jacobs, and I think it went away in the chat. Any thoughts about migrant communities in campsites? I'm not fully sure if it can be answered in the given time, but that's one game I just wanted to highlight. Yeah.
So maybe that's one takeaway question. This probably we can get back to him about migrant communities and chemsex. It's been highlighted, and again, just the level, the understanding of chemsex in migrant communities, heterosexual communities varies a lot. People do not understand the effects of alcohol, the effects of other drugs. So I think it would be good to give you a proper answer, which is not rushed. But I will ask Kata to take maybe 30 seconds to ask or maybe comment, and then Nataliia will come in and close. The session.
Just a comment. What I just said, I need, because I know there is a reason you went back to it. So I need to affirm what I just said again. There is an obsession about what trans people have between their legs, like our genitals. There's an obsession about that. And the patriarchy system wants to fuck us. So if there is an obsession about that, why are we not at the forefront of being included and consulted and hired? And it raises my high pressure, Denis. Understand? Yeah.
No, it is very important. We're seeing what's happening globally, like from the US and what effect that has had in Europe, and why the focus and the vitriol is targeted towards sexual minorities is crazy, and it's something that you're quite right to be upset about. I do hear you, and I feel that everyone here understands and hears your feelings about this. But thank you for sharing with us, your feelings, and of course for our panelists, for sharing with us, your expertise and your experiences. I'll invite, and of course I want to thank our audience. Of course, Nataliia probably will do this, but I just want to thank you on my own behalf to you for attending this webinar. Nataliia, I'll bring you in. It's time. Sorry, we didn't have any more time for you, but come in and say something.
Thank you, Denis. Thank you for this fabulous facilitation. Thank you all the speakers for your presentations and for this productive Q&A session. It's a high time to wrap up this meeting. The time flies very, very quickly. But as it was mentioned in the beginning, we will upload the webinar recording and the presentations to the Core Knowledge Hub webpage. So please feel free to check the presentations at your own pace. And let me please also invite you to the Core Knowledge Hub next webinars that will take place in particular on the 24th of June at 2 o'clock CET on digital tools to support people who use drugs and new quality standards for digital harm reduction. And the next one on the 3rd of June at 4 o'clock CET on community response on PrEP case studies of Ukraine and Cyprus. Please also check the registration links in the chart if it's more convenient to you. And we'll start disseminating this webinar today or tomorrow, so you will get more information about them. And after this webinar, just in 1 minute, you will see a post-event evaluation form. It's very short. Please fill it in and help us make our webinars better. Thank you and see you soon.